All right, so this is another shelf review series that I am doing right now. Sort of a hodgepodge of questions that includes a lot of women health questions, but then just general health stuff. So we'll go ahead and get started with question one. A 16-year-old female presents for a well child exam. She has no major complaints, and a review of systems is negative. She has no major history of medical problems or surgeries. She has a normal birth history. Social history is negative for tobacco use, drug use, or alcohol use. She is sexually active with a heterosexual partner. Exam is otherwise normal. Which of the following screening options would you recommend for her? Is it chlamydia screening, a complete blood count, urine pregnancy tests, or cervical cancer screening? So the answer is chlamydia testing. So the United States Preventive Services Task Force recommends selectively screening women for chlamydia if they are sexually active and younger than 24 years of age. And they also suggest screening all women over the age of 25 if they have increased risk for infection. There is no current guideline that suggests getting a complete blood count in someone that is completely asymptomatic, so that is something we should not be doing. She's not having any signs of amenorrhea because her review system is negative, so doing a urinary pregnancy test is not really indicated for screening purposes. And the United States Preventive Services Task Force recommends against screening anyone under the age of 21 for cervical cancer screening. So when you're studying and looking at health prevention, just remember that the United States Preventive Services Task Force is what you should be looking at. And I would try to commit to memory all of the grade A recommendations and grade B recommendations. The chlamydia screening for women under the age of 24 is considered a grade B recommendation, which is the second level of highest evidence. Grade A recommendations obviously being number one. But really, really important to kind of have that in your head so that when you're studying for your shelf exam, making sure that you're up to date with those prevention screening guidelines is going to be the most important and effective use of your time. So question two, Savannah returns to clinic a year later after having missed her period for 2 months. She presented initially with nausea and vomiting, and now she has vaginal bleeding. Exam is otherwise reassuring with normal blood pressure and heart rate. Which of the following tests would be the next best to get? Would it be A, a ProTime, INR, B, a comprehensive metabolic panel, C, a beta HCG, or D, an HIV antibody? All right, so, and I clarify that it should be a urine beta HCG. So, obviously the difference in the question is that, now she's having symptoms suggestive of possible pregnancy. And with bleeding within the first trimester, it's not a great thing to have. So really important to work that up. So when thinking about Savannah, the most likely diagnosis is either an ectopic pregnancy, spontaneous abortion, or idiopathic bleeding in a viable pregnancy. And some of the other labs that you can consider getting when you have someone present sort of similar is a complete blood count, a wet mount preparation to sort of evaluate for trichomoniasis, testing for gonorrhea, chlamydia, a urine pregnancy test, and a quantitative beta HCG if their urine pregnancy test is positive. And remember, the serum beta HCG in a viable pregnancy should double every 48 hours during that first 6 to 7 weeks. Usually, you're not going to see an intrauterine pregnancy on ultrasound until the HCG gets to around 1500. And ectopic pregnancies and spontaneous abortions, you're going to have a slight increase in the HCG, but it'll be much slower than the doubling for every 48 hours. Some evidence suggests that you can get a progesterone level, but it's really only helpful at really low levels of less than 5 or very high levels of 25 or greater. And low levels are usually correlated with evolving miscarriage or ectopic pregnancies. However, high levels, greater than 25, are usually associated with a viable uterine pregnancy. So mixed use might be a benefit, but not something that you would get all the time, but just something to keep in mind when you have this in practice. And management of an inevitable abortion includes one or all of the following. So you can certainly do expectant management or watchful waiting. Surgical options, which include dilation curettage with or without vacuum assistance, is also something that you can do. You can also do medical management, which is usually intravaginal misoprostol, which you can then repeat usually 72 hours or greater after. But you have to warn them about heavy bleeding. And then you also want to confirm whether or not mom is antibody negative or positive. If they're antibody negative, it's really important that you administer RhoGAM so you can prevent future presentation of antibodies if they have a positive infant. So question 3, just staying on the pregnancy women's health track. How is dating best determined via ultrasound in pregnancy with the gestational age within the first trimester? Is it A, bipyramidal diameter, or BPD? Is it B, head circumference? Is it C, abdominal circumference? Or is it D, crown rump length? It's going to be crown rump length. So in terms of ultrasound dating, the first trimester, usually the crown rump length is usually your best option. The second trimester is usually going to be BPD, head circumference, abdominal circumference, and femur length. Third trimester, usually the fetal size by that point can't be accurately used to assess gestational age. And it should not be used to change the due date because there's a plus or minus 3-week variation at that sort of stage of pregnancy. And just remember, the last menstrual period is usually the best way to determine gestational age. The imaging can sometimes be used in the first trimester if someone's unsure about their age. And the results of your ultrasound should be within 1 week of dating of a sure last menstrual period. So question 4, Miss Anderson is a very pleasant 55-year-old female who presents for issues with vaginal bleeding. She experienced menopause at the age of 51 and stopped having regular menstrual cycles at that time. She denies any burning on urination or pelvic pain, no issues with discharge. She is sexually active with her husband. She does use a topical estrogen compound for her symptoms of atrophic vaginitis. What would be the next step in evaluation of her acute complaint? Is it A, transvaginal ultrasound, B, urinalysis, C, urine pregnancy test, or D, a CA-125? All right, so transvaginal ultrasound. So common causes of abnormal uterine bleeding in just general female population, regardless of age, is cervical polyps, but typically in patients who are postpartum or perimenopausal. Endometrial hyperplasia, which is considered a pre-malignant condition with a 25% risk of progression to endometrial cancer. Oftentimes seen in women that have estrogen hormonal therapy or overweight. Hormone-producing ovarian tumors, which are very rare, and sometimes are not actually associated with any bleeding at all. And then endometrial cancer, which is the 4th most common cancer in women. And that's something that you always want to sort of know about when you're evaluating someone with postmenopausal bleeding. So in terms of someone that comes into the office with abnormal uterine bleeding who's postmenopausal, usually the workup can include a transvaginal ultrasound. This is a cost-effective way that's not very invasive, and you're really looking at the endometrial stripe to sort of make sure it's not really large. If it's large, you can obviously consider doing a biopsy, assuming bleeding improves. Endometrial biopsy is usually the gold standard, which can be performed in the office with a Pipelle device, and it has a sensitivity of 99% in detecting endometrial cancer. So what can sometimes happen is people will oftentimes do a transvaginal ultrasound, and if their endometrial stripe is thin, then they'll hold off on doing a biopsy. However, it's large and suggestive of possible hyperplasia, then you would proceed to a biopsy. It's also worthwhile to consider getting a complete blood count to look for anemia, but also thrombocytopenia. So I've seen a couple of patients develop postmenopausal vaginal bleeding from ITP or TTP. So it's really, really important to sort of keep that in mind. A TSH as well, thyroid stimulating hormone, and an FSH and LH are also useful. And FSH is helpful if you're worried that someone is menopausal. So question 5, which of the following is not a risk factor for osteoporosis? Is it A, corticosteroid use, B, previous fragility fracture, C, heavy alcohol use, or D, an elevated BMI? So elevated BMI is actually not a risk factor for osteoporosis. So osteoporosis risk factors include corticosteroid use, chronic, greater than 3 months, usually greater than about 5 milligrams of prednisone equivalent daily. Family history of osteoporosis, typically in a first-degree relative, so mother or sibling. Previous fragility fracture, which is defined as someone who sustains a fracture when they fall from a height that is equivalent to their stature. Smoking, heavy alcohol use, lower body weight, and Caucasian race. Now, because elevated BMI is not a risk factor for osteoporosis, being overweight is not necessarily protective, so don't encourage patients to do that. The United States Preventive Services Task Force recommends screening all women over the age of 65. if their risk of fracture is equal to 65 years of age. So there are some patients who are younger than 65 who do have increased risk factors because they're using steroids or they smoke, etc. And you're determining treatment for osteoporosis, it's really important to consider using something called the FRAX tool, which takes into account all their risk factors as well as their scores on their DEXA scan. Right now, there's insufficient evidence about screening all men. However, certain men can be at increased risk, particularly those that have a history of chronic steroid use or those that are on anti-epileptic drugs because there's possibilities that they're not metabolizing vitamin D effectively. Strategies to prevent osteoporosis include smoking cessation, adequate intake of vitamin D and calcium, and then weight-bearing activity is very important. And diagnosis of osteoporosis is usually someone that has a T-score on their DEXA scan of less than 2.5. Anyone between 1 and 2.5, they're considered osteopenic. And those individuals might benefit from treatment if they have an elevated FRAX score. Treatment usually involves bisphosphonates, Forteo, which is a PTH analog, which is expensive, raloxifene, which is a selective estrogen receptor modulator, and then calcitonin, which can reduce vertebral fractures, but not really effective for hip or other fractures. So which of the following is not true regarding hormonal therapy for treatment of menopausal symptoms? A, menopausal hormonal therapy increases the risk of osteoporosis. B, use can increase the risk of endometrial cancer. C, they're associated with increased stroke risk. D, use beyond 3 years can increase the risk of cancer. All right, so A, menopausal hormonal therapy increases the risk of osteoporosis. So the benefits of hormone therapy are 1, treatment of hot flashes, vasomotor symptoms associated with menopause, treatment of atrophic vaginitis as well as urinary symptoms, and also it helps prevent osteoporosis. But there are some risks. So there was a study called the Women's Health Nursing Study that looked at a number of women that had been enrolled that were on hormonal therapy. And what they found was that in that cohort, there was an increased risk of breast cancer, an increased risk of endometrial cancer, and then also increased risk of stroke and coronary artery disease in those over the age of 60, and also a slight risk of DVT risk. So currently, our goal is for people that have vasomotor symptoms, we try our best to avoid using hormonal therapy. There are other medications that you can certainly consider, including like clonidine, antidepressants such as venlafaxine. For atrophic vaginitis, you can sometimes use lubricating jellies. And if they're not really doing well, you can consider doing topical hormonal therapy, and then sometimes systemic hormonal therapy if it's really, really severe. There's been some new evidence that suggests that women that are under the age of 60, they're probably okay to take some type of estrogen therapy, and that we should probably walk back our recommendations of taking everyone off of them. But that's another conversation for later. Question 7. Mr. A is a 55-year-old male with a past medical history of gastroesophageal reflux disease, tobacco use, alcohol use, who presents to your clinic for epigastric abdominal pain. He's had a 15-pound weight loss over the previous visit a month ago. He also has symptoms of trouble swallowing solids, but no issues with liquids. What would you recommend as a next step for evaluation? Would it be a modified barium swallow? Would it be an EGD? Would it be a colonoscopy? Or would it be a right upper quadrant ultrasound? All right, so EGD. So alarm system symptoms for someone that comes in with dysphagia that makes you want to send them urgently to a gastroenterologist for evaluation include dysphagia, particularly with solids. So if it's solids only, that usually suggests that there might be some type of obstruction in the upper GI tract. If it's solids and liquids, that means that they might be having some issues with muscular dysmotility. The classic one is esophageal dysmotility or achalasia. So if it's just with solids, that sort of tips you off. The other thing is that anyone that's over the age of 50 that presents with the symptoms should be seen because the risk of cancer is higher in that population. Individuals that have early satiety, hematemesis, hematochezia, iron deficiency, anemia, adynophagia, which is pain, recurrent vomiting or weight loss should all be considered for endoscopic evaluation. The other thing is, dyspepsia is just a general all-tell term for bad digestion. It encompasses a lot of specific diagnoses, which can be functional dyspepsia, peptic ulcer disease, gastroesophageal reflux disease, gastritis, medication side effects, pancreatitis, malignancy. Causes for peptic ulcer disease commonly include aspirin and NSAIDs, physiologic stress, particularly those that are in the ICU. So all those patients typically will be on some type of acid suppression to prevent them from having any complications of stress ulcers. And then colonization by H. pylori, which is a bacteria that we know increases the risk of peptic ulcer disease, and tobacco use. The symptoms usually will get better with food and worsen on an empty stomach. And they're usually characterized by episodic or recurrent epigastric pain or aching. GERD is a chronic condition that is relapsing, typically worsens after large meals. Keeping along the line of peptic ulcer disease, Miss H presents with peptic ulcer disease based on examined history. Her physician orders a urea breath test, which is positive. Which of the following is the next best step in management? Is it A, treatment with famotidine by itself, B, treatment with omeprazole twice daily, C, treatment with amoxicillin, tetracycline, bismuth salicylate, or D, treatment with omeprazole twice daily, amoxicillin, and clarithromycin? And it says D, treatment with twice daily amoxicillin and clarithromycin, and along with omeprazole. So H. pylori is a common bacteria that can increase the risk of peptic ulcer disease, and it's typically implicated in about 90% of duodenal ulcers. Elimination after ulcer recurrence is usually associated with improved outcomes. And you can test H. pylori a number of ways. One is a IgG serologic test, which is helpful to determine if someone has been previously exposed, but it's not really effective at determining if someone has active infection. So the way I use serologic tests is if you have a population where the prevalence of H. pylori is low, this test is really effective at ruling out H. pylori. However, if you have a high prevalence of the condition, it's not a very effective test. And so some populations that tend to have higher risk are those that, for example, are from Southeast Asia or from Latin America. So generally, if you're going to use a test, the urea breath test or the stool antigen is probably the most effective because it actually assesses for active infection. And if you're going to do a urea breath test and a stool antigen test, it's really important to try to have them stop a PPI at least 2 weeks before you obtain the test because it can actually suppress the activity of H. pylori and can lead to a false negative result. You can also diagnose it via endoscopic evaluation. So if someone has an ulcer, they can do biopsies around the margins, and they'll actually stain it specifically for H. pylori. And if there's a presence of that, then that patient would be indicated for treatment. So treatment consists of triple therapy. And so just remember, anytime that you're treating H. pylori, after you've already diagnosed them with it, they should be on a proton pump inhibitor at a standard dose twice daily. That's going to be in every single correct answer. If they don't have the PPI included in that answer, it's probably going to be wrong. Amoxicillin, 1 gram twice daily, and then clarithromycin, 500 milligrams twice daily for 10 to 14 days. You can also do quadruple therapy, which is the PPI twice daily, in addition to metronidazole, tetracycline, and then bismuth salicylate. And then alternative treatment consists of a proton pump inhibitor, standard twice daily, with clarithromycin and metronidazole if they can't tolerate those treatments. Going back to Miss H, she undergoes treatment. She's doing much better overall. Which of the following is correct regarding the next steps in terms of her therapy or their evaluation? Is it A, her serum IgG should be checked to ensure she has eradicated infection? B, she should have her urea breath test performed while taking omeprazole. C, she should take her omeprazole or bismuth salicylate for at least 2 weeks and then have a urea breath test or stool antigen tested. Or D, she should undergo endoscopic evaluation. All right, so she should hold her omeprazole or bismuth salicylate for at least 2 weeks and then have a urea breath test or stool antigen tested. So eradication is confirmed generally via urea breath test or a fecal antigen test. And like we mentioned, sort of similar to when we diagnose H. pylori, it's really important to hold their proton pump inhibitor for at least 2 weeks before testing. If positive, you should consider retreatment for a resistant infection. So like, for example, if they're on triple therapy, you might want to consider quadruple therapy, or potentially evaluating them again with GI, sort of actually get a repeat sample, and then maybe sending it on for culture to sort of determine what regimen is the most effective for treatment. All right, question 10. Jimmy is a 4-year-old who presents with a fever of 103 degrees, but other vital signs are stable. He has a cough, but no increased work of breathing. On exam, he has a focal area of crackles heard in the right middle lobe. Pulse ox is 98%. What is the best next step? Is it A, chest x-ray, B, treatment with amoxicillin, C, treatment with azithromycin, or D, nebulized albuterol? Treatment with amoxicillin. So a couple of things that Jimmy has. One, he has fever. He also has cough. And he's luckily stable, right? So it seems that his physical exam doesn't show any increased dyspnea, which makes you think he can probably benefit from just outpatient therapy. It doesn't necessarily need to go to the hospital. The lack of wheezing points against asthma. However, he has a focal area of crackles heard in one specific area of along the right middle lobe, which makes you think he probably has some type of community-acquired pneumonia. And his pulse ox is 98%, so he doesn't necessarily need any further management. And to be honest with you, a chest x-ray probably isn't going to be indicated because it can lag about 48 hours after having symptoms or a diagnosis, so it may not be as effective. So you might benefit from severe treatment, which we mentioned. So when community-acquired pneumonia is suspected, chest x-ray is not necessarily indicated unless they're hypoxic or have respiratory distress or they're not responding to treatment. And then generally treatment for anyone under the age of 5 is going to be high dose amoxicillin to cover the most common cause, which is streptococcal pneumonia. And this is actually changed a little bit for adults too. Now we're actually recommending high dose amoxicillin for patients with normal lung function that are adults because we know that it's fairly effective for treating strep pneumo still. You can certainly consider doing azithromycin for anyone older if they're not improving, but generally amoxicillin is good enough. And then we mentioned x-ray is probably not really indicated because the kid's otherwise well appearing and not having any other symptoms. All right. So Gemma is a 10-year-old who presents for acute shortness of breath. She has a previous history of allergies and was admitted previously for a respiratory issue and required admission 2 years ago. She states that she has breathing medications, although cannot clarify what these are. On exam, she is slightly tachypnic and has increased work of breathing. Temperature is 98.5 degrees Fahrenheit and pulse ox is 98% on room air. She has diffuse wheezing in all lung fields. She receives albuterol and improves markedly. What treatment would be the most appropriate for her? Is it A, prednisone, B, amoxicillin, C, oseltamivir, or D, racemic epinephrine? All right, prednisolone. So, she has diffuse wheezing. Looks like she had a previous episode based on history, so it appears that she probably has an asthma exacerbation. And asthma is usually a chronic obstructive lung disease that's reversible, that is predicated by inflammation that leads to bronchospasm in the small airways of the lung. Typically associated with triggers, sometimes viral illnesses, oftentimes infections, but also environmental, right? So tobacco exposure, dust, all that can lead to just bronchospasm that can lead to an asthma attack. Typical treatment is albuterol. However, steroids are very effective at helping reduce inflammation, especially if they're presenting to the ER with wheeze and increased work of breathing. Generally with asthma, there is no role for antibiotic therapy. Occasionally, you can have patients that have a superimposed bacterial infection that can lead to an asthma attack, but in this case, there's probably no benefit. If you're worried about flu and there's a high incidence and they test positive, you can certainly consider using oseltamivir. However, prednisolone is probably a better choice, especially in this specific patient scenario. If they're really, really sick and they're not improving, and they're on continuous albuterol, and you feel like they need to be admitted, you can certainly consider the use of IV MAG and subcutaneous terbutaline for severe exacerbations that are not responding to typical treatments. And sometimes if they're on continuous albuterol and they're dyspneic, they may not be able to take anything by mouth, or they're not tolerating POs. Sometimes you can do IV pulse steroids. Or if they're on BiPAP, for example, that's another reason why they might benefit from IV steroids as opposed to oral prednisolone. But if that patient presents in urgent care or outpatient clinic, oftentimes we can treat these patients fairly effectively using asthma action plans. It's sort of giving an idea of how often they're supposed to use their albuterol and then providing them a course of steroids. So I'm going to end this lecture because it's right at 30 minutes, and the goal of this was to have these sessions be 30 minutes and no longer. So next week we'll redo this with some additional questions. Feel free to email me if you have any other questions. Thank you.